In case 2, we had anti-NMDA encephalitis, and what it presented with, a woman came in for issues with behavioral changes and weight loss. And she came with her mother, and her mother reported that she was emotional, tearful. I guess that's probably the same thing, but she was emotional, tearful, anxious, forgetful, and her thinking had slowed down. She also reported that, due to the weight loss, most likely, she didn't report why it was due for, but she also reported that she had been amenorrheic. So she had no period. Now her vitals were unremarkable, but she did have a slight left facial droop. At this point, the major things in this presentation, you got behavior and weight loss kind of together, to the point that she's amenorrheic. She's lost something like 20 kilograms, which is close to about 42, 44 pounds. And so in this case, you should probably thinking psychological. When labs are done, she's +1 on protein in her urine, and they also note that she has a positive urine drug screen for tetrahydrocannabinol, which is THC is the main ingredient in marijuana that gets you high. Other than that, all of her blood work and everything looks basically normal. And next thing you do, send her, hey, go follow up with your primary care physician, and we're going to send you with a recommendation to see an OB-GYN for your amenorrhea. Everything else, it just looks psychological, right? So she comes back in 2 weeks. We don't know yet if she's seen her primary care physician or not, but she comes back in and her confusion is getting a lot worse. She begins perseverating on ideas, meaning the same idea comes back to her over and over again. She might ask the same question many, many times. She has a more noticeable facial droop, and she's beginning to get headaches. Something I forgot to write in is that her gait has become unsteady. So unstable or unsteady gait. So we're getting from the gait and from the facial droop, we're getting definite motor involvement, but it looks like from the perseverating and the confusion and her memory problems, we're getting we may be getting problems in the temporal lobe, and that's just a possibility. It could be more diffuse than that. Now, the fact that she has no indicators of infection, what I mean by that is she's not feeling weak and fatigued. She doesn't have any fevers, chills, night sweats, pain, shortness of breath, abdominal pain, or rashes. So, in essence, we're trying to rule down infection and possibly paraneoplastic. So paraneoplastic would be, so if you had cancer, you would often you can get night sweats and stuff like that with that as well. So let's build this differential diagnosis list, and I'm going to give you this great mnemonic that I came up with, impairment. And so what does impairment stand for? So let's start with I. And the mnemonic impairment is for when you have generalized neurodeficits. And so the I is going to stand for intracranial. And this intracranial can be for a couple of things. So it can be hydrocephalus, or it could be like pseudomotor cerebri. The M is going to stand for myelin. So if you have a demyelinating disease. The P is psychiatric. The A is going to stand for autoimmune or axonal. So if you have axonal damage, then that would also cause problems. Now with the I, here's where we get a little bit of overlap with other things. So this could be an infection. I'm just going to leave infection there in general because we're going to talk about in a second encephalitis and meningitis. And the most common causes of those are infections, but they have some non-infectious causes as well. And then you have some things that would cause some infections that would cause some variants of encephalitis. For example, prion disease might cause a spongiform encephalitis. So we're just going to leave infection by itself. The R is, you can see this in children, it's going to be Rise disease. And that's basically if you have, it will usually happen a few days after a viral infection. And it was associated with aspirin. There's some debate about whether or not it actually is associated with young children taking aspirin. But it can cause personality changes, it can cause delirium, disorientation, confusion. So some of the stuff that we're seeing, these generalized neuro problems. M is going to be, like I said, meningitis. E is going to be encephalitis. N is going to have neoplasm and nutrition. And by neoplasm, it could be some primary neoplasm like a neuroblastoma, or it could be paraneoplastic syndrome, so just keep that in mind. And then nutrition, we're mostly looking at stuff like B vitamins, thiamine, for example, with beriberi disease. And then last is going to be trauma. So if you got trauma, maybe you're leaking cerebrospinal fluid and it's causing pressure on the brain, or any number of things with trauma. So this is the mnemonic for neurologic impairment. Oh, and before I forget, I want to add one more thing to this. The T is going to also have two meanings. The other one is toxin. So traumas and toxins. So heavy metal poisoning, for example. Or in our case, we know she had a positive drug result for THC. So like I said, we want to break these down a little bit more. So intracranial, we're talking about intracranial pressure specifically, and that would be, so if you have hydrocephalus or something, so you increased intracranial pressure of some kind. There's a lot of different reasons. One of them, for example, would be pseudomotor cerebri, which is when your intracranial pressure increases for no obvious reason, and the signs and symptoms of that mimics a brain tumor. So it mimics a tumor. I got the pen way too wide. Let me turn that down. So yeah, so tumor is what it's going to mimic. The thing is, with our case, pseudomotor cerebri is common in obese women. So our woman is like way underweight at this point. If you took the time to calculate her BMI, it was I think it was right around 19. However, she did say that she had lost a lot of weight before that time, so maybe she was obese. I mean, so it's something to at least look into. Check intracranial pressure. Do that with either an MRI or a CT to look at the size of the ventricles and that kind of thing. Then we have the myelin. So let's zoom in here and talk about myelin. There's demyelinating diseases. The three of them that everyone seems to be hitting on their study guide would be multiple sclerosis. And multiple sclerosis is going to give you your neuropsychiatric problems like depression, irritability, anxiety, impairments in memory. So you got your neuropsychiatric. It also causes motor changes, typically spasticity. So you're looking at upper motor neuron problems, gait disturbances, so walking with a funny gait. And both of these things are things we've seen in our case. It's typically you're going to have sensory changes, paresthesia, numbness. And also visual problems like blurred vision, loss of vision in one eye, double vision, those kind of things. So just because I think this is probably a high-yield topic, it gets brought up quite a bit. MS, you have neuropsychological changes, which include behavior and memory. You have motor changes, which includes weakness, spasticity, and hyperreflexia, so typical of upper motor neurons. And then you have sensory deficits, which include numbness and paresthesia, which this would resemble a polyneuropathy. And then you have the cerebellar problems, which includes ataxia. Gait can also be considered a muscle problem, but I put it under cerebellar as well. And this is just the short list, but I picked out the big highlights. Next in the myelin category is a disease called acute disseminated encephalomyelitis. This has all of the features that we just described for MS. The thing that differentiates it is it's caused by a preceding infection. And so if you've had a recent infection, or in some very, very few cases vaccination, kind of almost afraid to even say that because I haven't looked at the literature to see how closely they're resembled. But most of the time when it's a vaccination, it's like 1 in a billion. And it's usually not statistically significant. But I haven't checked in this case. The other thing that's going to make it different from MS is it's going to present with fever or some type of infectious-like quality, and you can even be unconscious, which causing problems with being unconscious or in a coma is not very common for MS. And the last thing is it's caused by a single attack on myelin, whereas MS is recurrent and constant. And you can typically use brain imaging to distinguish old lesions from new lesions. I'm not sure exactly how that's done, but you would look and say if there are old lesions mixed with new lesions, MS would be the diagnosis. If it wasn't if you had just new lesions, you would look for this acute disseminated encephalomyelitis as part of your differential as well. A rare subtype of ADEM is called acute hemorrhagic leukoencephalitis. It's very rare. It's just like a hyperacute presentation, so it moves very rapidly and it includes hemorrhaging. And the last thing we're going to talk about is PML for a myelin. PML is progressive multifocal leukoencephalopathy, and it's usually caused by the JC virus. And so this is also going to fall under infections. This is often only seen in people with severe immunocompromised situations such as AIDS. And so it's not going to be common, but if you have somebody who's presenting with MS-like symptoms and they have a history of an HIV diagnosis, this would be something you would want to look for. Also, people on things like chemotherapies or anything that would harm the immune system, immunosuppressant medications, this would be a possible diagnosis. Now for psychiatric, whenever you have somebody who's having alternating changes in behavior, one of the things you're going to want to look for is schizophrenia. And so that's got to be on the differential diagnosis. And then, of course, she had lost a lot of weight, so you would want to keep eating disorders and then depression as well. Now let's move on to autoimmune and axonal. With autoimmune, this is where we would get our anti-NMDA receptor encephalitis. It was discovered, as I understand it, as recently as 2007. There are some even newer ones. For example, there's one called Clippers, and it stands for chronic lymphocytic inflammation with pontine perivascular enhancement responsive to steroids. It was described in 2010. Whenever you have antibodies against GABA, specifically GABA B, you can get a limbic encephalitis and also a cerebellar ataxia. With autoimmune diseases, the one thing you're going to want to look at is indicators of autoimmune. So you're going to want to look at erythrocyte sedimentation rate, C-reactive protein. You'll want to do an ANA titer. Possibly look at thyroid antibodies, HLA, and you're just going to look at, if you have something positive right here, you're going to want to start doing probably a bunch of different antibody titers for different things like anti-Purkinje, anti-WHO, antithyroid, complement C1q, rheumatoid factor, those kind of things. Some diseases can resemble autoimmune, for example, syphilis, and you'll want to do a blood test for FTA. You can want to do a Lyme disease titer, and you'll do like an HbA1c for diabetes. Now, in treating this, some of the mainstay stuff is going to still apply for autoimmune, so IVIG or plasmapheresis, plasma exchange. And then some of the pharmacological treatments are all going to be the same. So prednisone would help. If you can't tolerate prednisone, you might try methotrexate, or possibly rituximab. And again, Pharmacology, all of the pharm cards for this block I've got posted on Quizlet, and I'll put the link down in the description if I remember to do that at the end of this. Now keep in mind the autoimmune disease that I'm describing, I'm doing general neuro. I haven't described any of like the peripheral or stuff you would see in the spinal cord alone. So things like myasthenia gravis or Guillain-Barré or Lambert-Eaton myasthenic syndrome. Those are all going to be in a later video for I think week 7. As far as axonal damage goes, with that, the main thing is due to brain injury, brain trauma, but the difference where instead of having a direct impact trauma, it's going to be a shearing trauma. So shearing, if you can imagine that your brain was like a tube, if you were to accelerate and then decelerate, then part of your brain might stretch over and have like a pulling effect in one direction, and that would stretch and snap the axons, and it often causes persistent vegetative state and things like that. If you saw axonal damage in a baby, for example, that would indicate shaken baby syndrome, and so child abuse would be, you would probably have to report that immediately. Now, infection's a pretty big thing as well. We're going to break infection down to things that cause meningitis and things that cause encephalitis. For encephalitis, it might be easy to remember that bacteria or infections have no heart, and so heart would be herpes. It would be all the different herpes family viruses, arboviruses, rabies, toxoplasmosis, which would be Toxoplasma gondii, and there are other Toxoplasma species, and then trypanosoma, so I think it's an O, trypanosoma. For meningitis, you might want to remember that these bacteria are spineless, and that's spineless with one S missing. So for that, we'll say strep A, Streptococcus aeruginosa. P would be polio, which I don't think this is really a great thing to have on a differential, but it's on everybody's study guide. But it's basically done away with in the entire world, so you know, it is what it is. So I would be influenzae, Haemophilus influenzae, for example. Influenzae, and that would most likely be type B. N is Neisseria gonorrhea, and I don't really remember how to spell Neisseria, but Neisseria gonorrhea or any type of Neisseria meningitis. The first E will be for E. coli, and this will be seen mostly in younger patients from 0 to 6 months. L is going to be Listeria. The next E is going to be Ehrlichia, Ehrlichia. And Ehrlichia, remember, is an arbovirus, so remember other arboviruses can also cause meningitis as well as encephalitis. Then the last S is going to be strep P, Streptococcus pneumoniae. A few infections of the central nervous system, so bacterial infections that aren't mentioned here would be things like Treponema pallidum or syphilis. So don't forget about the tertiary syphilis or any of the spirochetes for that matter. And then the other thing is that there are other arboviruses. So for example, Molly's study guide has Borrelia burgdorferi. It's more of a, it is a spirochete, but it's another tick-borne, so keep that in mind as well. And lastly, I'll mention Brucella. So anyhow, I'm not going to cover the microbiology. If you want to cover all of the micro on all of these, I recommend the super objectives that are on box. And I had already covered JC virus as well, so that covers most of the infectious causes of general neurosymptoms. Now we're to raise. Raise is usually associated with a viral infection of some kind, and then if you take aspirin, a young child takes aspirin during a viral infection, they can get raise syndrome. or I've heard it pronounced rise. I really don't know. So like you have eyes there. Now for the meningitis and encephalitis, I want to be very specific. We already talked about infectious causes, and so some things that you want to look at are non-infectious causes. For example, sarcoidosis and rheumatoid arthritis can both cause non-infectious meningitis. Now on encephalitis, again, there's infectious causes. There's also autoimmune causes. People with autoimmune causes of encephalitis have the worst outcomes statistically. But then there are a few cases of encephalitis where no specific infection or autoimmune cause could be found, and in those it was just idiopathic encephalitis. So for the most part we've covered encephalitis. Now for neoplasm and nutrition, the thing that we're going to talk about, so a lot of people have in their study guides about paraneoplastic syndrome. I'm not going to recover that here because most of the time what that ends up being is an autoimmune process. However, there are some things with neoplasms in specific, not paraneoplastic syndrome, but neoplasms specifically, like if you have a neuroma or a neurofibromatosis or a neuroblastoma, any of those kind of things. If you have a growth inside your head, you're going to get something called mass effect. And that is basically where you have growth pushing against the rest of the brain, pushing it out of the way or pushing it against another structure. And so you can have generalized defects with that. So you're going to have a specific focal defect where the mass is, and then you're going to have general effects as well due to the brain being pushed against itself or being pushed against the walls of your cranial cavity. With nutrition, everybody focused on thiamine in their study guides and stuff, and that probably is the big one. So thiamine, you get something called beriberi syndrome. And beriberi syndrome, with a loss of thiamine, you can have wet or dry beriberi, you can have infantile beriberi, and you'll get something called Wernicke's or Korsakoff's syndrome, or sometimes the two combined are called Wernicke-Korsakoff syndrome. Now, lastly, there's trauma and toxin. Trauma, I think, is self-explanatory, but with toxin, I don't think I saw toxin in any super objectives. I've read through a couple, and with toxin, heavy metal toxicity, a big deal. Also, other toxins that can get into the CNS include ammonia, so ethanol, nitric oxide, glutamate excitotoxicity. There's also a lot of other organic toxins like tetrodotoxin and botulinum toxin, tetanus toxin. The botulinum tetanus, that's not really a big deal for generalized neuro, but for peripheral neuro. And then anything else, if any type of thing that would damage the blood-brain barrier would also cause generalized neuro problems. So let's see if we can rule out some of these causes of generalized neurodysfunction. So intracranial, we'll get back to that. We did an MRI and a CT and we saw a mass effect. So there's some type of intracranial pressure. We can't make a diagnosis right away off of that, but we know that that's there. Urine drug screen came back clean, so we're going to rule down a toxin. We also went ahead and did a lumbar puncture, and so what we saw was that there was no indication of infection. There was an increased, let me write this over here. There was an increased protein in the lumbar puncture, and there was an increased red blood cells, and here's the big kicker, the pressure was normal. So I'm going to put pi for pressure. Pressure was normal. So where's that mass defect at now? Let's go ahead and cross that off of intracranial pressure. There's a mass effect, but it's not from hydrocephalus. Now the question is, why do we have increased proteins in red blood cells? Red blood cells is easy. We just we didn't have a clean puncture. We just got some of the blood from whenever we made the puncture. So we're going to go ahead and just disregard that unless we see evidence of hemorrhage. And in fact, what we did see was we couldn't exclude hemorrhage whenever we did the MRI. It still had to be on our differential. So maybe I shouldn't have marked that off so fast, but that's one of the things you're looking at. Is there a hemorrhage? And that kind of thing. Protein may be elevated because of the increased red blood cells, so keep that in mind as well. We also do a gram stain and a PCR for on the CSF to further rule out infection. We do a mini mental status exam, and that rules up a neurologic cause rather than a psychiatric cause. With Reye's syndrome, this has been going on for quite a while. We don't have a history of viral infection, and also the age doesn't really fit very well, so we'll go ahead and mark that off. Now, we did Koenig's and Brudzinski's test to check for meningitis. Both of those things were good, so we ruled out meningitis. So go ahead and mark that off. Now, what we haven't ruled out yet is demyelinating process, autoimmune, and axonal. So let's talk about axonal really quick. Axonal would not have progressiveness unless you were repeatedly exposed to the shearing trauma that I described earlier, but we haven't ruled out autoimmune. So we still have a possibility of a demyelination. We have a possibility of autoimmune. We have a possibility of encephalitis still, and neoplasm and nutrition. Now, the impression from the CT was that she had bilateral medial lobe hypoattenuation. So a hypoattenuation, it ruled up, it said the impression was either encephalitis, hypoxic encephalopathy, metabolic abnormality, or other etiology. So we've had encephalitis ruled up, metabolic, which could be also nutritional or neoplasm, depending on what type of metabolic problem it is. And it said it could also be hemorrhage. So, I mean, we've ruled down trauma quite a bit, but we could rule it back up maybe just a little bit just to cover our P's and Q's. But then we do the MRI to follow up. The MRI says, no, it's probably not a hemorrhage. So what it does say is that the patient demonstrates marked signal abnormalities in the basal ganglia and temporal lobes, and there's also some polyps that have been identified in the maxillary sinus. Now we run some vitamin B1, B6, B12. We find they all come back normal, so we're going to rule out nutrition. Again, everything's negative on the viral infections whenever we check that. We do a CSF analysis, and the one thing that stands out is that there is a myelin basic protein in the CNS, and that is where we get our increased protein from. So whenever, we still don't have a diagnosis, but we know we have a group of things that it could be. We have these things going on, the MRI. So I'm going to go ahead and rule down neoplasm. There could be a neoplasm, it would be really small, but it hasn't been seen on the MRI or the CT scans. At this point, we're going through the case. They've done several of them to this girl. And so whenever you have a failure to diagnose using less invasive image studies and lumbar puncture, it calls for a biopsy. So I'm going to write biopsy. Now when we do the biopsy, one of the things we find is Luxol fast blue, H&E, and it's found in the macrophage. So what does that mean? The Luxol fast stain stains myelin, so it's for a myelin stain. And if you have myelin in the macrophage, it suggests a demyelinating process. So anything on your demyelinating list of diseases, you just ruled it up really fast. We also see a couple other things. So that we see CD68 infiltrates, and that means, so CD68 is on microglia, and when they become activated to macrophages, this is what you're going to find in the biopsy. So they become activated to macrophages. Not a huge deal. The next thing we see is that we see CD3 T cells and CD20 B cells. And that indicates that this process, this demyelinating process, has an immune component to it. So any demyelinating autoimmune disease just got ruled up. We go ahead with that biopsy and we do a silver stain, and the silver stain is just looking for fungi, and it comes back negative. So we've ruled out viral through PCR, we've ruled out bacterial because we've cultured it, we've ruled out completely fungal, so all infections have been ruled out. So we give this young lady a working diagnosis of demyelinating encephalitis, and this is, we say, most likely due to inflammatory or autoimmune. So since it's most likely due to inflammatory or autoimmune, what are we going to do? We're going to give her some plasma exchange. So I'm going to put PE, plasma exchange. We change the immunosuppressants that we're giving her. And we want to do some extensive antibody testing to see exactly what disease it is. So we send off some of her blood, and what comes back is an anti-NMDA receptor antibody. So N-methyl diaspartate receptor antibody. And we know, because we're really smart students in medical school, we know that anti-NMDA encephalitis is associated with some type of neoplasm. And so we do CTs from head to toe and find nothing. Now let's talk about the disease really quick, and that'll be all. So anti-NMDA receptor encephalitis. And so the first thing we want to say is that there are basically two types, or two main categories. There's those with no demyelination problems, and those with demyelination. Now, those with demyelination have a lower risk of having a teratoma. But the problem I have with this is there is no proposed mechanism for how demyelination occurs with anti-NMDA receptor encephalitis. So I can't tell you why there is demyelination. I can just tell you that there is. In fact, it's like about, the literature I read from March of 2014 says 23 out of 691 patients with anti-NMDA receptor encephalitis had MRIs with features of demyelination. So we're going to put 23 right here and 600, well, out of those patients, so out of the 691, 23 had demyelination. So that leaves 668 that did not have demyelination. Now, out of these 23, only one had a teratoma, which is the main malignancy that's associated with this disease. Now, it's important to note that originally this thing was being described as a paraneoplastic syndrome because it has a strong association with various neoplasms, specifically a teratoma. However, more and more they're finding this disease in cases where there is no evidence of any type of malignancy or growth. And so what that may suggest is that sometimes the various tumors, for example, a teratoma or Hodgkin's lymphoma or a testicular germ cell tumor, most of these tumors that are associated with anti-NMDA typically carry NMDA receptors, and that could be what's causing the immune system to start attacking the NMDA receptors, just to kind of keep the tumor under control. However, it may also suggest that maybe there is an infection or a virus or some other autoimmune process that occurred to cause the body to start producing an immune response against the NMDA receptor. Now, the disease also has some specific phases. We're going to talk about those really quick. There's the prodromal phase, then there's the psychotic phase, then there's the unresponsive phase, And the last is the hyperkinetic phase. Hyperkinetic phase. In 70% of patients, the disease will start with, it will look like an illness. So you'll have headache, low-grade fever, fatigue, irritability, nausea, maybe even diarrhea and vomiting. Then when you get to the psychotic phase, it's associated with behavioral changes, just like we saw. So I'm going to put behavior. And it's associated with possibly, like some patients will develop seizures. So you got to be aware of that as well. And some ataxia or coriform movement. So it may look like there's some chorea or Huntington's. Then in the unresponsive phase, they're not going to respond to any verbal commands. They're just going to look at you, smile inappropriately at times, various type of things. And so sometimes this has been associated with, like in the past, people think that this may have been what was associated with demon possession. And so the psychotic as well as the unresponsive phase together would have like demonic possession-like qualities to it, I'm guessing. Then finally, in the hyperkinetic stage, you're going to get a lot of autonomic problems, autonomic stability. And so any type of, it could be sympathetic, it could be parasympathetic. So you could see increased heart rate or decreased heart rate, bradycardia or tachycardia, or any type of arrhythmia or hypotension, hypertension. And the other thing you're going to get is dyskinesias. So dyskinesia is problems with moving. You're going to get things like lip smacking. Also, teeth clenching, grimacing, those kind of things. So just movements that are rare, random, and for no reason. And we went over the treatment and everything. The diagnosis, we basically went over that. CT, not very great for it, but MRI can help to narrow things down. Ultimately, you want to get a sample of either the CSF or the blood that shows anti-NMDA antibodies. And so once you do that, the treatment's fairly straightforward. If your immunosuppressants don't work, or if there's a relapse, then you can start treatment with rituximab or cyclophosphamide. And with this disease, the prognosis is not too bad. So 15 to 25% relapse, and usually about 75% will recover function. So catch it early and prevent relapse, get the function fully regained and everything, in as many patients as you can.